My name is Terry King. I'm the Chief of the Division of Breast Surgery at Dana-Farber Brigham and Women's Cancer Center and the Associate Chair for Multidisciplinary Oncology in the Department of Surgery at Brigham and Women's Hospital. The trend in breast surgery and breast cancer treatment in general over the last 2 decades has been a less is more approach. Many of our investigations in both surgery, radiation oncology, and medical oncology have been towards identifying appropriate patients where we can offer less extensive treatments. In the setting of breast surgery, this has most notably been in the area of the amount of lymph node surgery that is performed. And we have moved away from complete lymph node dissection in the majority of patients now. Even in patients who present with cancer in their lymph nodes, we are now using much more preoperative chemotherapy to eradicate that disease in order to be able to offer the sentinel lymph node biopsy procedure at the time of surgery. When we do that, the sentinel lymph node biopsy procedure then allows us to check those lymph nodes that were once involved by cancer. And if we can demonstrate that the cancer is now eradicated or killed in those lymph nodes, then we no longer have to remove all of the lymph nodes in those patients' arms or under those patients' arms. So this has been a really significant paradigm shift for us, knowing that we can eradicate lymph node disease, accurately demonstrate that it's gone, and limit the amount of lymph node surgery that is being performed in our patients. Other areas where, again, we're looking for ways to dial back treatment include the use of genomic assays to select patients where we can omit radiation therapy, either radiation therapy that is delivered to the breast in cases of breast conserving surgery, or radiotherapy that might be delivered to the lymph nodes in cases with patients are found to have positive nodes. So there are several genomic assays that we are being tested to identify low-risk patients where radiotherapy can be safely omitted from the breast cancer treatment paradigms. Similarly, there are genomic assays that are being used to tailor systemic therapy. So assays that are being used to decide who really needs chemotherapy, who will benefit from chemotherapy, and who can we actually just treat with endocrine therapy. This is important because we know that chemotherapy, again, is associated with significant side effects and toxicity, which impacts quality of life. And so using genomic assays to truly identify those patients who are going to benefit from that treatment has resulted in sparing many, many women the toxicity of that chemotherapy. And finally, the next horizon is even further dialing back our local treatments. And there are several ongoing clinical trials examining the use of ultrasound to look at the axillary lymph nodes. And if those lymph nodes look normal by ultrasound, then omitting any type of surgery to the lymph nodes altogether. This, of course, may put some surgeons out of work, but that's okay. We're always looking for ways to, again, decrease the morbidity or extent of our treatment for the betterment of our patients' outcomes. So if these trials demonstrate that having a normal ultrasound can obviate the need for even a sentinel lymph node biopsy without compromising long-term outcome and without compromising the ability of our multidisciplinary colleagues to make their treatment decisions, then this would be a big step forward for our patients as far as minimizing the morbidity of our treatments. So these are all active areas of investigation, many ongoing clinical trials, again, trying to tailor therapy, trying to limit therapy and really reduce the morbidity of our treatment while still maintaining the excellent oncologic outcomes.